virtual healthcare. We are live and online, and we're pleased that you're either watching us on Rogers TV or online on your computer. Thanks for joining us. My name is Keith Rose, and I'm your moderator for this evening. Tonight, we're going to be focusing on patients' virtual care. What do you mean by virtual? Because we're virtual too right now. It really is that people are seeing patients remotely or at a far distance that is connected by technology. So we're not side by side and we can't touch them. So that's kind of the meaning of virtual. We're virtual. Our healthcare is delivered virtually now. So we're going to hear, is it a good thing? Is it a bad thing? Is it something that once COVID is over, we should revert to something else or some modified version? So I'm really looking forward to the conversation with our three speakers. At this point of the show, I kind of like people to put their hands up. But I know I can't see your hands, but I'm going to pretend I do. So how many of you out there in the audience has interacted with one of your healthcare workers by virtual means? So put up your hands. I'm putting my hand up. You can put your hands up too. So 50% of us here on the show have actually interacted by virtual means. And that's what the stats are out there too. Many people, over 50%, have actually used the system for virtual healthcare. Before I introduce the three speakers, just a couple of comments. First, we miss our live audience at the MCC. I missed your laughs, I missed your claps, and I missed chatting with you after the show, and we hope we'll be back real soon. We are a live format tonight and virtually, as I said, and we do that for several reasons, but sometimes we have the odd little glitch. And just like we've all learned to do, when we have glitches, we just need to take a big, deep breath. And tonight, somebody else is figuring out what the problem is and carry on. So we may have the odd spot. Now, let me introduce our three speakers. Sam Berman. Sam, put your hand up. Okay, hi, Sam. Sam is a lawyer. He's got an extensive background in human rights and immigration, and he is the director of the Virtual Family Physician Network in our community. Elisa Matheson, I think we all know which one's Elise. Thanks for putting your hand up. Is a nurse by training. She has lots of experience with telemedicine and is currently the coordinator for the telemedicine for Simcoe County. I'm looking forward to her discussion specifically about the role she's playing with the long-term care homes. And Jeff Galiski. Jeff, raise your hand. Okay, hi Jeff. Welcome back to the Our Health program. You were here for stress in 2019, and thank you for coming back. Jeff's a family doctor here in Midland. He's been here for almost 15 years, and he's currently the Chief of General and Family Practice at Georgian Bay General Hospital. There are more details about our speakers in your bio. You'll see the thing here. I'm not sure whether I'm showing it the right side or not, but the bios are here on the back. You got that electronically, or you can access it now. So just before we begin, some collective thank yous. First of all, to the Our Health Advisory Team, and specifically to Larry Arnold, who took the lion's share of organizing tonight's event. Thank you, Larry. To our sponsors, who I'm going to come back to, our 7 sponsors, just in a little later on in the show, and specifically mention each one. And to the very committed staff and volunteers at the Midland Cultural Center, and especially to Rogers TV, who are in the background tonight, but certainly working very hard. Our format tonight is very similar to the previous 27 events. Each of our speakers will be chatting with me and with each other. And then after I thank the sponsors, we'll flip to a question and answer session. That's your chance as audience members to ask us questions. You've had a chance to send them in to Jared by email. You can continue to do that while you're watching the program. Jared's picking them up. Or if you're watching us on Facebook Live, you can become part of the chat line there. So look forward to receiving your questions. A comment about our next program, 6 weeks tonight, same place, Same time, that's December the 3rd, we're hosting a program called Living Your Best Life with Arthritis. That event, we have 3 speakers, a patient who's had a recent hip replacement, a physiotherapist who's very interested in conditioning, and an orthopedic surgeon from Collingwood. I think it's going to be a lively evening, and we're going to get things moving. So look forward to seeing you all then. So without any further hesitation, I'm going to pass the mic or the baton over to Sam. Give us your spiel there, Sam.
Okay, I do come to this.
What does the law have to do with healthcare? Come on, tell us.
I know it's going to take me a while to convince you of that, but I'm going to try. I was, for many years, a lawyer, mostly for immigrants and refugees, and worked as an immigration judge for several years. While doing that, refugee law is an element of human rights law, and there are all kinds of procedural rights that refugee claimants and others are granted, whether it's a right to a full hearing, the right to counsel, the right to an appeal, the right to have your decision in writing so you can review it. There are literally hundreds of these procedural human rights. I took a year off and I was teaching immigration law at the University of Toronto Law School. And during that time, it's about 15 years ago, I started hanging out with the health law professors because they were young and exciting and interesting. And at that time, there was a severe shortage of family doctors in Ontario. There were millions of people without a family doctor. It's better now. It's obviously not completely better, but there have been many steps that have been taken to improve it. But when I came to learn what it meant to a person not to have a family doctor, I realized that if you look at the consequences of that, and you look at all of the other rights that are protected, that access to primary care, in my view, is a fundamental human right. And if you look at the terms of our Canadian Charter of Rights and Freedoms, it says there that everyone has the right to life, liberty, and security of the person. There have been a number of studies done about what the consequences are of not having access to a primary care provider. And by that, I mean a nurse practitioner or a family physician. In a study done by one of the major Canadian research institutes called ISIS, they found that there were 118,000 excess emergency room visits and more than 17,000 excess hospital admissions of patients who didn't have a primary provider. And of course, that makes sense. If you're feeling ill and don't have a physician or nurse to talk to, your only alternative is a visit to emerge. So I think people understand the lack of access to a primary care provider as an issue that gets stressed in the emergency department. But the issue is actually much more serious than that. In a large review of literally hundreds of research papers conducted by the former head of the Royal College of General Practitioners in the UK, they looked at what the outcomes are of having a primary care provider and not on the early mortality of the patient. And the shocking answer is that they found that forgive me for scaring everybody, but your risk of an earlier death goes up by 53% if you do not have a primary care provider, up to 53%. So if you accept that access to a primary care provider is a basic fundamental human right that has substantial consequences to every resident of Ontario who's a no-hip holder, then it becomes incumbent on us to find solutions to the lack of access. So this is a long way of explaining what the heck does this have to do with telemedicine? And the answer is this, that telemedicine is an effective way of taking resources in one part of the province, for example, GTA, and using those resources to support another part of the province, for example, Midland. In fact, I developed this program with the Department of Family Medicine, McMaster, and the intention was to serve the patient populations all along James Bay. So we've started that, but in the meantime, there are, in the central Ontario, a number of family health teams, some very progressive, including the wonderful family health team in Midland, whom I adore. They're progressive and caring and supportive. So thank you if they're watching. And we started this project. So we provide virtual care. And what happens is a patient who does not have a primary care provider goes into an exam room. They're there with a nurse and they see the doctor on a TV screen. And we always say that we are second best, but we are far superior to other alternatives. So we provide the full range of care to a patient, and the patient will see the same nurse each time and the same doctor each time. They develop a relationship, and they're provided the full range of care, which is important. There is some technology now that supports this. There's some very cool technology. There's an electronic stethoscope, which the North Simcoe Family Health Team has been using. So what happens is it's a Bluetooth electronic stethoscope. The nurse puts it on the patient. The doctor in King City, Ontario, puts it on watching his TV screen. They hear exactly the same thing. So that helps to bridge the chasm of virtual care. There are special ear, nose, and throat cameras, and iPhones now take great pictures of rashes and insect bites that we can transfer over. So there's all kinds of things that we can do to try to approximate the level of care that you would get if you were in the same room as your physician or nurse practitioner. What we also try to do is to say that we will take care of patients until they find a local primary care provider. So when there becomes capacity, if there are new doctors in town, we just transfer the patients over there and they continue with their care.
So Sam, I know you're doing this in the area of Midland and Penetanguishene, but are you doing it across other sites in Ontario?
Yes, we started in a small town sort of between Cobourg and Peterborough called Campbellford. And I have clinics in Peterborough, Smith Falls, Perth area. And we had a clinic way up in Englehart, Ontario. I didn't know where it was until they called me, but it's way north of Timmins. And then we are starting clinics in Saskatchewan and Attawapiskat along James Bay.
So are these communities that are significantly short of a family doctor for each specific patient?
Yes, so each of these communities has the chronic shortage of family physicians. There are periods where there are more than less. But what happens in the smaller communities is that if a physician or two retire, it puts several thousand patients out of care. And so we would come in and manage those patients. And then when they recruit physicians, then we'll just pass the patients over. But in the meantime, the patients' chronic conditions are managed: diabetes, kidney disease, heart issues, all of that.
And are all your referrals to family doctors generally in the GTA, are they all to family doctors, or are they sometimes to specialists or to nurse practitioners? How do you decide how to triage your patients that come in?
So in my case, we're trying to replicate the family physician experience. And so all of our physicians are family physicians in Southern Ontario. There is a cohort of family physicians, often young moms, who aren't able to devote their time to an in-person practice. And so telemedicine is a nice alternative for them. There are some late career physicians that have sort of given up their practice, but they still have it and they're still interested, so they provide care. And one of our physicians has MS and just prefers to work from home.
So you're not robbing Peter to pay Paul. You're taking people that would otherwise may not be doing anything and recruiting them to work with you. Great.
That's right. And we're also taking from an area where there are an adequate supply of physicians to support areas where there are not.
Okay.
That's the whole idea.
Great.
I was going to mention a couple more things quickly. One is that while I love the whole idea of telemedicine as a way of addressing this gap in care, it's not all good. What's been happening is that technology goes faster than brains and ethical conduct. And so the fact that something can be done virtually doesn't necessarily mean it's better. So what's been happening is there are a lot of small clinics that have started up, And what they do is provide episodic care, which means they'll check a sore elbow, but they won't check your prostate. And it means that if you think you're getting adequate care because you can get your rash looked at or get a prescription renewal, they're not looking at the asymptomatic risk and disease, your family history, your blood work, to see if you are at risk of something or have something, and to get that managed early. So that's one aspect of telemedicine, family medicine, that I'm not very supportive of. But otherwise, for us, it's been a godsend.
Tell me, when a patient sees one of your physicians from the GTA, do they have a record of their encounter? Is there something, because I suppose at some point the GTA physicians may be saying, you know, if this doesn't get better, you probably maybe something less significant, maybe you should go to your local emergency department. So do they have a record of what's happened with the GTA doctor, or is it just kind of word of mouth?
No, we keep a full electronic medical chart for every patient. So that includes any investigations, lab work, imaging work that's been done, the results of any referrals to specialists, visits to emergency departments. They're all kept in an electronic chart. And when that patient finds a local physician, the entire contents of that chart are sent with the patient to the physician.
So I'm wondering more specifically about an episode. They saw somebody for a rash and it didn't get any better, so they go to the emerge department, but they can't remember, I don't know, they didn't take their drugs. Can they get access to that electronic record to show the emerge doc, or is that under development?
So there's always a gap in cooperation on medical records between hospitals and family physicians. We do belong to something called OLIS, which is a central repository of all the blood work and diagnostic imaging for a patient. So that can be accessed by the hospital. And also, we, of course, would fully cooperate with the hospital if they're asking for information about the patient. And we would just send that along.
Okay, great. Lisa or Jeff, do you have any questions of Sam?
Not so much a question, but I can definitely say I was on the ground floor there at the family health team when Sam, brought this to them. And I think it's been incredible. I think, and I've stayed in contact with the nurses that are running it. And I've heard such amazing feedback, and that it really is serving a need, and that it's being well received. And, the first few appointments that I partook in when we got it up and running, it was, there's always a few little kinks. There's always a few little things to smooth out, but it's amazing how quickly those things do get smoothed out. And then you're just in this flow of things, and it can become really seamless healthcare delivery.
Because we had great staff to work with, including one of your guests.
It's a mutual admiration society here. Jeff, what are you hearing in Midland about this?
No, really, I am really excited, right? And I think we owe Sam and his team a thank you, and really he should be commended for his innovation and his vision and his, I think, true understanding of the needs of kind of chronically underserved communities like Midland Penetanguishene. I am pretty active in our recruitment program locally for primary care providers, and it was just over a year ago. I remember meeting. We had many recent retirements. We had a couple of physicians moving away, and we really didn't know what to do, how to help serve these patients in our catchment area, and lots and lots of meetings and things. And eventually, with the family health team in Midland, the partnership with Sam was made, and we haven't looked back. So thank you, Sam. It's been great for our community.
Thank you. My thanks go to you.
Yeah. And Sam's a pretty humble guy, but he probably didn't allude to this, but I said to him, why do you do this? Is this about the money? And, for Sam, it's not about the money. He may not tell you that, but it's about his passion for making sure people have access to a family doctor. That's why he does this. So thank you, Sam, for speaking to us, and I'm sure you'll be more of our conversation as we proceed with the evening.
I can't thank you all enough. Thank you.
Okay. Lisa, tell us about what you do as a telemedicine coordinator for.
Yeah, thank you. Thanks for having me. I think this is a great opportunity to bring some knowledge and some light to this very specific type of nursing job. So Telemedicine Coordinator is, it's historically been an RN position that was started back in 2011 with the 9,000 Nurse Initiative, and the LINs created this position to increase efficiencies in healthcare, I believe was some of the wording. But you will see other types of people doing this type of work as well. But specifically, telemedicine coordinating is what I've been doing for many, many years at family health teams, at mental health hospital, and now with the county. And to explain it, it's great that Sam went first because I can really use this as an example. So when he's talking about there's that nurse that you're seeing, then that's that same nurse in that appointment with your doctor that you're seeing over the screen. Well, that telemedicine coordinator is that nurse typically. And that's someone that's wearing a lot more hats than people might realize. So they are that nurse that's appointment, doing these vitals, doing assessments for the physician or the specialist, taking orders, supporting that appointment, and being the hands and whatever the doctor really needs. But prior to that appointment happening, there's a lot of coordination and there's a lot of steps and a lot of puzzle pieces that have to come together to actually have that be a successful appointment. And so telemedicine coordinators are the ones that kind of put these pieces together. So for example, when I was working at the family health team, it became very clear that there's certain needs and we really need to get access to these different specialists. Maybe it was a respirologist or a psychiatrist, but this is where there was need showing. So first it's, as a telemedicine coordinator, okay, I need to find these specialists that are going to connect with us, that are going to dedicate, a portion of their time to taking our referrals and connecting virtually. And then I'm going to, build referral forms for them, upload them into the EMR, and create a pathway of communication between family doctors, me, the coordinator, the specialist, and the patients and their family, right? So as a telemedicine coordinator, you could be the one building that kind of infrastructure to have these appointments go on. So for example, once you get a doctor messaging me saying, okay, I want this patient to go have, they need a psychiatric consultation. I said, okay, great. Well, what kind of psych is needed? You might have a few different options. We review the options, choose the best one, complete the referral requirements. We send this all off. This is all digitally done. None of this is over paper. This is all done paperless. And then I'll have my contacts there at maybe it's CAMH or maybe it's an independent psychiatrist that we've connected with. And we'll then collaborate and go, okay, this is the date and time. Let's make sure that works. I'm communicating with the patient, maybe making sure they have certain blood work done before the appointment, any other requirements that are needed. And then they actually have the appointment and it goes, as you would imagine any appointment does.
So tell us about the actual visit with the specialist, because we've graduated to specialists now, which is kind of telemedicine's original work. What Sam's done is a spin-off kind of. What does it look like? How do you? Do you see the specialist? Do you hear the specialist? What kind of system do you have to reach that specialist who is often many miles away?
Well, now all you need to have is a computer with a cam and a good enough speaker integrated into it, which is wonderful because years ago you would have had to have had what's called a room-based system, and they were provided by the Ontario Telemedicine Network, or organizations had to purchase them, and they could be tens of thousands of dollars, and they're still in use today, but we don't have to use those now. Now it can all just be done over a computer using a secured platform. So, you discussed and brought up the point that, we're doing a Zoom right now. So this is a virtual connection. So there's platforms that are like this, but specifically geared to be used in a healthcare context.
Okay. So Jeff,
Look and hear like we do.
I watched a I don't know, there was an advertisement came from a hospital foundation that shall go nameless about 6 years ago saying our telemedicine equipment is outdated. We need $50,000 to renew it. Is that what's happened to that telemedicine equipment? Is it obsolete? And have we switched to laptops and computers almost exclusively now?
Well, I can say that, for example, at my past employment or moving forward with this equipment and it's coming to end of life or they're starting to break down, I'm not recommending you invest the money in getting them fixed up. So they are going to become more and more obsolete as they become end of life, this equipment.
Okay. Jeff, is that I don't know what's happening at local hospital. Have you got telemedicine equipment still there? Or is that pretty well gone by the way?
No, I agree. I think it is slowly evolving, but it's still in use, certainly within the hospital for those specialist consultations. So it's still in use, but I agree it is slowly evolving. I think the key, as Elisa mentioned, was having that RN support, right? And I think that really has made the program successful. We still do use it quite commonly for the assessment of inpatients needing specialist consultation that we can't provide locally. So there's still certainly a role for that, I think, in hospital-based OT and equipment as well.
Okay, thanks for clarifying that. I'm sorry if I misunderstood that, but that's a better understanding. Lisa, tell us about your current position in long-term care, because long-term care homes are in the news again, unfortunately. So.
And actually, as of this Sunday, I am being redeployed to work and support the Beaton long-term care home. That is now.
Okay. Okay.
So definitely my mind is there and wanting to lend a hand as best as I can. But I started...
Tell us what you're going to do down there, what it's going to look like. So Beaton is outbreak mode, unfortunately several deaths, many patients, 30, 40, somewhere in that neighborhood affected, staff affected.
Yeah, and honestly, I don't think I could even speak to what it's going to look like. I'm going to while I get there.
Okay.
And I've just, and as an RN, that's where I'm probably going to be most of use right now. But as far as this position goes and long-term care and virtual care, I started March 23rd, I believe. So I started in the thick of things.
Okay.
And, the position a year ago is very different than what it is right now. And that, typically it would have been, you have a telemedicine coordinator that's going into all these long-term care homes across the County of Simcoe to support them, creating these clinics with specialists, creating these connections with their family doctors, using that big room-based equipment. Whereas now you can't. With COVID, you can't be going from home to home to home to home. That would not be safe as an infection control policy. So what I'm doing is I'm really working with the long-term care homes to just help educate them and build their capacity to own and run their own telemedicine care pathways. Right? To work with them to integrate it into maybe their policy, into their roles and positions, so that they're not dependent on an external, but this is something they can run themselves.
Okay, so what kind of patient are you looking for? Connections between a bedside nurse at one institution and a bedside nurse at another institution, or are you looking at coordination of conversation between patient and a specialist doctor or a family doctor? What is the connection?
So, what I'm doing is I'm working so that the staff at the long-term care home can apply it as they see is needed, right? So it's being used in many different ways to do rounds with family physicians, with the nurse at the bedside of the resident, connecting with the family doctor, doing their rounds.
Okay.
Being used to connect with specialists, it's being used to connect with family members. It's being used in many different ways, but the idea is that they need to be confident and capable in implementing this technology, and then they'll find and they'll know the ways to use it because, there's so much being opened up virtually. You just have to be confident and capable in initiating that or receiving those requests.
So would your work even entail patients connecting with CCAC workers, because they come into the long-term care homes sometimes, they come into retirement homes anyway, or with hospitals they came from? Is that part of your mandate?
So really my mandate is to support the use of virtual care in healthcare. So that can be all encompassing. You know, I also worked with a hospice to help them get up and running with virtual and opening, you know, so that our long-term care homes could access bereavement services, right? So really the possibilities are endless as far as what connections can be made. It really depends on what the needs of the residents, what the needs of the patients are.
Okay. And the other absolutely essential part of connecting in challenging times like this is how do patients connect with their families? Is that part of your one of the things that you advise people on?
Yeah, I've been advocating actually ever since I worked at the mental health center. I've been really working with social workers and advocating for anyone that's in any kind of institution or anywhere where they're not able to physically see their family members to connect virtually, and for that family member to be a part of the care conversations, for them to be invited to, you know, these appointments, these conversations that are about their family members if they want them there, and for that to be an open road for them.
Okay. So what are some of the challenges you're facing? I know that the kinks aren't all ironed out and the concepts are wonderful, but from when you're actually trying to implement this, what are some of the challenges you're seeing?
Yeah, there can be a steep learning curve for sure. And, you know, with long-term care especially, you don't have a telemedicine coordinator nurse working at each one of these sites. So you're asking someone to stop what they're doing, think a different way, use a different tool, and know how to do that with a different kind of software. It's actually a bigger ask than people might realize. So there's a learning curve with the software, and now there's so many new platforms coming out. It's kind of muddied the water in a few ways, because you might have, you know, a doctor that wants to use one type of platform, a family member that could only connect through a phone call, a long-term care home that's using another type of platform, and a specialist that's another. How do you make that all come together?
And assuming they all have a good internet connection too.
While assuming everyone has a good internet connection, which everyone definitely does not. Yeah. So those are real challenges, and it doesn't say that there are no solutions. There's a solution to all those problems, but it takes a bit of patience, and it takes a bit of collaboration and just willingness to see this through. And then once you do, the healthcare that's possible, I think, is quite astounding.
You got a success story you can share with us?
I mean, I think I've been in so many different types of appointments where it's been touching, because you could have patients that typically would be traveling, you know, to Barrie every single week for their chemo and their pre-chemo appointment. Now, instead of having to do that extra drive every week, they're just going down the road, you know, or staying at home now, right?
Okay.
So, or there's people that have connected with, you know, specialty programs in Toronto that otherwise would have been completely inaccessible to them, you know, because the hospitals in Toronto can be creating some very unique, specific types of specialty programs that, you know, you have to be dedicated to driving to Toronto to partake in that. Now you actually have access to it here. So, I mean, I've seen people really access care that they otherwise would not have.
So do you think that through virtual care, you'll be able to reduce the number of transfers out of long-term care to acute care hospitals, just merely by having a consultation in the middle and somebody helping with the ongoing care?
Absolutely. I mean, I think there's no question that you could reduce the number of transfers by having a video conferencing eyes on. I am promoting specifically to have that video chat where you have eyes on and not a telephone call necessarily, although telephone calls can be useful. But I think in a lot of situations, I'm really promoting that these doctors have the eyes on, which is the video component, not just a telephone call.
Okay.
Of course, telephone consultation has huge merit as well.
Okay. Sam or Jeff, do you have any questions for Elisa? Sam or Jeff?
Right.
Do you have any questions for Elisa?
I'm just curious, as what do you think things will look like for, I think, patients in long-term care maybe 5 years from now? I think things have really shifted, and I'm just curious as to what you think the future might hold for these patients in terms of access to care.
So I mean, what I see is that virtual care is integrated into pathways in long-term care home, and it's something that's adopted, it's sustainable. There's kind of a known time and place to use it. And I see it being an enhancement of a resident's care. And I'll say in long-term care, we say residents, not patients, because this is where they live, right? This is not the hospital setting. So I see them being able to avoid a lot of costs on family members as well, because this is family members that are paying for those transfers, and that is costly. Right? So I think it could be something that is just beneficial for everyone when it's used at the right time and the right moment for the right person. And I see that being a really integrated part of the care in 5 years.
Okay.
And that internet access is better for every single one of them.
Right.
Yeah. Sam? Sam, your thoughts?
Oh, I just I'm quite curious to hear what Jeff's experience is in telemedicine. But before that, could you just give us a list of what specialties or what specialists use telemedicine?
Yeah, absolutely. I mean, I can speak personally that I've been involved in appointments with endocrinologists, respirologists, oncologists, psychiatrists, child psychiatrists, geriatric psychiatrists. There could be geriatricians. Let me think, what else is there?
So one of the things I'm hearing
social workers
is that you haven't talked about the hands-on specialties. So obstetricians, surgeons, is that an area that is to be developed, or have you had some?
No, absolutely. With surgery, I mean, definitely orthopedic surgery is something that's running, especially for these pre and post-op appointments.
Okay.
So, I mean, a lot of pre-op appointments can happen virtually. And if you think about, and often it's post-op when there's no complications. If there's complication, it's going to be an in-person. But if there isn't any complications, then you can have these orthopedic surgery post-op appointments. And
Great. Thank you for the work you do, and all of us will be thinking about you as you transfer to Beaton. We're not done tonight, but big kudos to you for taking that on. So.
That's fine. Thank you.
Jeff, how many years have you been involved in telemedicine, and tell us about your earlier experiences?
Right. Thank you, Keith. Really, when I look back, telemedicine actually was part of my residency training. And as Elisa alluded to, I think the early OTN systems were really cumbersome, really confining to one room, usually in the basement of the hospital. So that was sort of my first experience, was actually as a resident in the academic field learning. So that was my first experience. As we've discussed, it's really evolved a great deal since then. But that was my first really exposure to that telemedicine component.
Was it being used in education at that point too?
It was. So I did some training, we call it the rural residency program. So I spent my final year of training in Aurelia, but still connected with my base hospital, Toronto East General. So each week we'd have our academic half day, and I'd join in remotely with the team down in Toronto. So that was how my first exposure with the OTN system came about.
Okay. We've all talked about telemedicine, but you just said some initials, OTN. Do you want to just tell us what that means, what specific part of telemedicine that is?
Sure.
Okay.
Right. That was the Ontario Telehealth Network. And again, that was the program that was introduced many years ago with, again, that equipment, usually hospital-based and quite institutionalized. Now that program has evolved to a virtual platform accessible by anyone with a laptop, basically. So it's the software, everything has become much more streamlined lately.
So is that the system for telemedicine that you don't, that's the go-to person, Lisa, for you, and the go-to person for you, for Jeff, if you want to, that's a whole system that works together, is it, that OTN system?
So, and just to chime in, so the Ontario Telemedicine Network, the keyword there is network. So they've created a secure network that this platform can run off of. But there may be now, I think there's another platform that's also piggybacking onto that network as well.
Okay.
The idea being that it is a secured, safe to use in a healthcare context network.
Okay.
Yeah, they are kind of the standard. They've been around the longest. They are the most established, but we are seeing new options coming up as well.
In my early days, my recollection is that it was set up primarily for pediatricians to provide access to some spots in Northern Ontario. That was one of the big uses of it. And then it evolved, but primarily to bring Northern Ontario patients with Southern Ontario doctors. That was the original intent of that network. But of course, it's gotten much bigger and better since then. So sorry, Jeff, to interrupt you.
Good. Now, I guess, sorry, getting back to your question, Keith, it was more about sort of other kind of virtual care options. And I think that we use that term virtual care quite broadly, I think, to define anything that's not I think, traditional in-person patient visits, whether it be on the telephone or an email communication or perhaps even a text, and then the video-based platforms. Some hospitals are using different web-based platforms, and then again, essentially the gold standard, as we call it, the OTN network. So I think it kind of spans anywhere from a telephone encounter to the full virtual and video conferencing platforms.
So somewhere around the middle of March this year, I think there was a word out that non-essential services were to be discontinued, and there was fear of spread of COVID between patients, between doctors, between healthcare providers, and emergency departments stayed open, but only for those that were the sickest. And so you very quickly had to figure out an alternative to your more familiar patient visit to your office, sitting in a potentially crowded workroom or waiting room, and lack of PPE supplies. So, I mean, you had to make a shift over a very short period of time. Do you want to tell us what that was like and how you made the decisions you did?
For sure. No, I really distinctly remember it was the weekend of March break when sort of that word came down that all non-essential encounters and visits were to be done virtually. So I think we all had to just adopt and shift really quickly. And it was sort of a moving target. But over the course of a few days, we had to change the way we booked patients, change the way all of the encounters were structured, and to do essentially the vast majority of encounters, at least for the first 3 months, March, April, and into May, most everything was done virtually, and it was quite a challenge, right? I think providers, doctors are sometimes resistant to change. I think change is a bit difficult for patients when they've been accustomed to coming in and seeing their primary care provider and in person for years, and trying to have that same encounter over the telephone or over a video platform was a big change for everybody. But I think we as a province did a reasonable job in adjusting and adopting pretty quickly out of necessity. But I think it's worked reasonably well. And as I said, it's continuing to change, but I think it's here to stay as well.
So Jeff, count the number of patient encounters you think you've had in the last, we've been in this game now about 8 months now.
Right.
How many patient encounters have you had? That you've done virtually?
Virtually, it's countless, but probably at this point, it's in the office setting, well over or half, probably at least 2/3. When I look at my list from the last couple of days, at least 2/3 are probably still done virtually. We've been trying to slowly ramp up the inpatient visits, because I think some things that were thought to be a little less urgent or could be deferred 3, 4, 5 months ago are really now something that we need to see in person. So I think that that proportion of inpatient visits is slowly changing, but again, I think it's an ever-changing target as well. But at this present time, we're probably over 50% still being assessed virtually in the primary.
So I think you told me that virtual for you is primarily through telephone. So why did you choose the telephone?
I was certainly doing a little bit of the virtual care before the pandemic, before March. Certainly had my OTN account up and running and registered. Some patients found it helpful. I quite frankly found it just a bit less efficient, and a lot of sort of upfront legwork for the staff, for myself, for the patient, just to get that platform up and running. And I've truly found I can provide, I think, access and efficient care over the telephone, and then essentially triaging patients for which I think need an inpatient visit. So I found, frankly, the telephone quite efficient, and just keeps the day moving, and allows, I think, access to the greatest number of patients. As I think was said earlier, I still think nothing beats certainly an inpatient assessment in person, but the video component would be great as well. It's just sort of trying to match that efficiency and providing access to as many people as we can.
Okay. In your experience with these many, many virtual visits, are there some patients or groups of patients you've been able to say, you know what, this isn't working? Mm-hmm. And yet there's other patients where you say, I wish I'd done this a long time ago. Mm-hmm.
Mm-hmm. No, I think the virtual visit certainly has a lot of benefits, right? It certainly goes without saying that I think that the safety benefit was the biggest one in March that brought us to this point, certainly limiting exposures for our patients in the waiting room and for our providers to too many patients. I think there is an element of convenience, perhaps being able to be at home and having a consultation, a visit in one's home. I think it potentially provides increased access for some, where even coming to the doctor's office is a barrier to obtaining care. So I think there's certainly a lot of benefits that we've identified since increasing the proportion of virtual visits.
So have you had to say, you know what, I really am interested in this problem. You have patient X, but this isn't working. I can't understand you. You can't understand me. How often does that happen?
It does happen.
Maybe with your bedside manner, it never happens, Jeff.
No. It is challenging, right? And I think there are certain, presentations that work really well for a virtual visit, whether it's sometimes sort of management of chronic conditions and prescription renewals, kind of review of tests, review of specialist consultations. I think mental health concerns can often be addressed virtually, and some kind of simple, more recurrent illnesses, I think, can be dealt with quite effectively virtually. Some things I found quite challenging. I think the more acute concerns, whether it be chest pain or breathing problems, those things I think require an inpatient assessment. The skin conditions and rashes, that's been interesting with respect to obtaining kind of good quality photos or videos, and the issues of transmitting those safely. So I think things like the more acute presentations, often skin changes, skin rashes, I think are best seen in person. And I think often some of the musculoskeletal bones and muscles often do require an assessment in person as well. In my experience, I've found it quite efficient to have a brief telephone consultation first, and then sort of triage the patients whom I think need to have an in-person assessment as well.
Okay. So how do you patients like it? Do they tell you, is the second or third visit easier than the first? What are your patients telling you? Because we're very interested in what the healthcare workers think it's like, but from a patient perspective.
I tried to, I actually, just preparing for tonight, I did try to ask some of the patients what they thought. And I think I'm fortunate. I think patients are quite open and frank with me, and some really like it for the reasons I think I mentioned, the convenience, the access. And some patients really don't appreciate this as much as we think that they might. And they really think that the in-person assessment and interaction, I think, adds a bit more to the visit, to the encounter. Some points that I think the patients made, it's always a little harder to communicate when you're not in the same room. I think you lose some of that nonverbal communication as well. So I think most patients are kind of adjusting to it, but I think many still are hoping for the day when we can get back to a more open in-person consultation.
I thought you'd say that patients like my smile, because if I'm seeing them in a clinic or in the emergency department, I have to wear a mask.
That's right.
But virtually,
yeah.
No masks.
No masks.
No masks. It is so hard sometimes to tell what people are thinking with the mask on. So anyway, Jeff, that's great. How does your office staff like it?
It's been a big adjustment. I think there's a lot of work that is done differently by our staff. The phone never seems to stop ringing. The staff too is I think has to be thanked for their commitment to supporting our offices, and I think just trying to work with the patients and to try to I think just reassure them that they can still receive care. We're still here. We're still able to help them. But yeah, again, it has been a big adjustment for the staff since March as well.
So in any change in medicine with physicians, there's at least three bodies involved. There's the CPSO, the College of Physicians and Surgeons Ontario, which is the regulatory body and provides advice on standards and what you should and should not do. There's the Ontario Medical Association, which guides us through many things, but the obvious one being the fee schedule. And then there's the Ministry of Health, who actually pay the bills for healthcare. Have those three organizations been a help, or trying to get everything to change the way you wanted it to in a week? Have they been able to do that? Or tell us a little bit about your experience with those interactions.
Right. It is quite a complex system, the way I think healthcare is provided in Canada and in Ontario specifically. I must say, I think all the involved parties were quite open to change. And fortunately, I think the regulatory college and the OMA with respect to negotiations with the ministry and payment models. I think we're very fortunate that all three organizations were able to become aligned quite quickly. And I think that allowed essentially seamless transitions in care later in March of this year. So there's certainly always some wrinkles and hurdles to overcome, but I truly think we're fortunate to have the supports we do in Ontario to sort of make this work without any large gaps.
Has the experience with your peers across Ontario been similar to yours, Jeff, or have you found that there's kind of some that really like it and some that don't like it and some that don't do it and some that's all they do? What's the sense out there?
I think my experience is mostly in primary care and family medicine, and I think most of our colleagues are working similarly with a mix of in-person and virtual or telephone consultations, and I think everyone's comfort level with the ever-changing landscape of this pandemic it's a little bit different, and some providers are more comfortable seeing patients in person. Some are doing more virtual care, but again, I think everyone is more or less aligned and on board with the patterns of care for primary care in the province.
It's good to hear. I'm going to open it up here for questions from Elisa and Sam. Elisa, and I'm hoping you'll turn the question around that Jeff asked you about the future, and now you can ask him what's the future in his office. If I can put words in your mouth.
Jeff, what's the future in your office 5 years from now?
Right? And we didn't plan this either. So. No, seriously, I think primary care needed this push to make virtual care work. I think there always was. I think there was a necessity to get this moving forward, and I think Sam really alluded to it with the access and just these chronically underserviced areas. So I really think this is one benefit that will come out of the pandemic. Quite frankly, is the push and the persistence of the provision of virtual care or virtual primary care, family medicine, nurse practitioner clinics and things. I think we needed this push to virtual care. And I think 5 years from now, this will be a regular part of all of our practices. I don't know what the proportional will be, but I think virtual care, telemedicine is here to stay. And I think 5 years from now will definitely be a part of our practices. So
Jeff, and Lisa, you've described an interaction between primarily a patient and a healthcare worker. Jeff, yours has been really focused on what you do in your own office and your interactions. Do you see a day when those interactions will expand to pharmacists, to physiotherapists, to other healthcare workers, or will expand to systems of communication that we currently don't have, let's say, between specialists and family doctors? I mean, where do you see that going?
Well, I will say that it already has expanded. I mean, pharmacists are already using this, and I think a lot of specialists, it might not be OTN necessarily, but they're finding a platform to use. And there are more secured platforms that are becoming available that are a little more simple and a little more user-friendly at times. So you're seeing there. I don't think that's even a future question. It's already happening.
Okay. Jeff, your comments on that question?
Again, I think things will continue to evolve. I think the interactions with other members of our healthcare teams will be more seamless and be done more efficiently going forward. And again, I really think this is what we need to just make the changes happen, and just a bit of momentum to keep this moving forward.
Okay. House calls. Will virtual care take away house calls? Or are house calls already a thing of the past?
I don't think the house call will ever disappear completely. I think I agree. Probably the number of house calls that are done by primary care providers has decreased over the last couple of decades. But I still think there's a role for that in-person presence, that visit to the home, I think the interaction with the patient's environment, and to observe where they're living, and all those extra, I think, determinants of health that can only be really assessed by being there in person. So yes, I think in general the number of house calls has diminished, but I don't think that virtual care will ever truly take over for a house call. And I think especially in the palliative care setting, I think that that in-person assessment and visit is still essential.
Okay, I'm going to put a plug in here, Jeff. There are some things that you can't do in your office anymore. Well, you can never vaccinate babies. Do you want to put a plug in for this year's flu shot, which I'm sure you can't do virtually unless you know something that I do?
No, that's right. So certainly, I think the current guidelines in Ontario would support essentially universal vaccination for our seasonal influenza. Right now, we're focusing on those patients more at risk, available in many of the family health teams and primary care offices and community pharmacies. So yes,
okay.
Flu shots.
Okay. Thank you. Thank you for adding to my little blurb here. Okay, thanks, Jeff. At this point, I'd like to take just a few moments and thank our sponsors. If TJ or Elizabeth, you'd put the slide up. Thanks very much. We've shown you on the screen the logos of our 7 sponsors. And just to reiterate, there's 2 very large healthcare organizations that are sponsors, Georgian Bay General Hospital and the Hillcrest Village Care. Those are very different organizations, but nevertheless organizations that have been very supportive of what we do here at the Our Health program, and we thank them for their ongoing and continuous support. There are 4 individual healthcare providers who are part of our sponsorship group, and the sponsorship just isn't for one program, it's for an entire year, 7 events. Dan Lauren, the optometrist on Elizabeth Street, Anita Federici, the psychologist on King Street, Andy Audia and his hearing centers, which are around this Simcoe County area, specifically in Aurelia. I think he's got an office in Midland. He's got an office in Elmville. I'll stop there because I might get it wrong. And to Aaron Fairbanks, who runs the Advanced Foot and Orthotic Clinic. So to those 4 practitioners, thank you for sponsoring us. Thanks for being a part of the Our Health group. And then we have one rather unique sponsor, Maple Pub, and their good food there, and Sandro Bezza, the head chef, and the restaurants they're running. So to all 7 sponsors, thank you. We really appreciate your support in so many ways. Now's come the time of the evening where I can ask for some questions. And so we have got some that came in advance. Let's go for this one. So, having experienced a virtual appointment some 2 to 3 years ago, and then the reaction from my GP, which was very negative at the time, I was somewhat dismayed. I received a very quick appointment to an eye specialist, so not a great experience 2 or 3 years ago. With COVID-19, we're seeing many virtual appointments with GPs and specialists prior to the face-to-face appointment. What changed the physician's attitude to adopting this as something that might be better and might work versus from 3 years ago when they kind of looked back and said, here's why it won't work? Who wants to tackle that one? Sam, why don't you tackle that one?
1 word, 2 syllables, COVID.
Okay.
it became, necessity is the mother of invention. And in order to protect patients, physicians, staff, nurses, there was a reduction in in-person visits, of course. And by necessity, it required contact virtually. And so that was led to the explosion of what we call telephone medicine.
Okay.
Not the full range of telemedicine, but it's...
So push that a little bit farther. We've always had rural patients. We've always had patients in James Bay that haven't had good access to primary care or couldn't get to primary care in the sake of it. But that didn't seem to be enough to push virtual care to those regions, except in some areas, but certainly not all areas. So what was different about COVID?
I just think it was it exacerbated access issues. I mean, your family physician or nurse practitioner was not available for an in-person appointment. And so if there was a need that had to be addressed, it had to be done virtually. And physicians did not have a lot of incentive to use virtual care when they could just have the patient come in. But that no longer was an option in many cases. So I just think it was a question of necessity. Okay.
Elisa, any further comments on that? Or?
Yeah, I think I absolutely agree with Sam. I also think that people became more willing to do things a different way. And I think it wasn't just the family doctors, but I think kind of everyone banded together to be open-minded to do something a different way, out of necessity, out of, you do what you can, and we get through this, right? So I think that everyone has become a bit more open-minded. It has made my work easier in that regard, in that some of these people that typically would have never considered these, some doctors would have never considered this. Now I'm going to consider this. I have to consider this. It's my practice to deliver care. I physically cannot do it in person, so we're going to make this work.
Yeah, somebody said to me the other day, the best incentive for change management is to take away what you currently have. And they took away your family visits. Really, they took away your office visits for at least a period of time.
Yeah.
So, Jeff, why don't you if a patient asks you, is my conversation with you private and secure? What do you say to them?
I think it's certainly a reasonable question. And I think that with all of the different platforms, whether it be the telephone or whether it be a Zoom conversation or even an email or a text message, I think there always is an element of potential insecurity. I think most patients, accept that very small risk, but I think we do have an obligation at least to discuss that and bring it up with our patients. I think with respect to privacy, I think there's always we look at it in a different light, that perhaps there are certain conversations that patients might feel more comfortable having over the phone or virtually as well, where they don't necessarily have to come in. So I certainly think that the privacy issue is valid, but I think there are other ways to look at it as well.
So when I call the bank sometimes on the telephone, they will, if they want sensitive information like a social insurance number or a card, a Visa card number, they will say to me, I'm going to use my technology, and they make it more private. So when I say the number, it goes to some special privacy line. And then when I'm through with giving them the number, they come back on as usual. Is that option available on phone lines, or are you pretty comfortable that phone lines are secure?
Mm-hmm. Certainly not something that I'm aware of, Keith. I think we all are quite trusting in our technology. But no, I'm really not familiar with that other mechanism yet for the telephones. And I don't know if Sam has other experiences that way or.
Yeah, I could jump in as well. And sorry to butt in.
No, I was going to come back to you, Lisa, because you were quite specific about the privacy.
Yeah, I have some strong opinions about this, you could say, just because I differentiate that there are more secure and less secure options. And I think when a physician or a specialist or someone is offering care to a patient, saying, "Are you okay taking this?" when they know that it's a less secure option, I don't think that's right. I don't think a patient should have to accept a lower level of privacy because that's a physician's preference. And I know that's strong, but I do believe that. And I do believe we all have the right to access to safe care. And that's why there are platforms that have call features. You can have phone lines added to them, and they are secure lines. And, they are password protected, and there are these levels of security, and they are harder to coordinate. And there is more of a learning curve to implement, which is why I think not all physicians have, and often the ones that do have staff that can support that, right? And not everyone does. So, there's no judgment, but I do think when it comes to a patient's right, I do personally think that they have the right to say, I'll do a virtual call, but I want it to be on a secure platform.
So do you think that secure platform is just going to follow this? I mean, in the heat of the moment, you had to do what you had to do. And if you'd waited for a secure platform for a telephone line, well, you'd probably still be waiting for it. No detriment to the phone companies. People are trying to do their best. But do you think that will come, Sam? Do you think that'll come sooner or later?
Well, one of the reasons why we use the Ontario Telemedicine Network is that it's purported to be a secure and encrypted service. So that's our most comfortable platform for performing virtual services. Phones, I just don't know enough about, but what occurred to me is that somebody could be listening in on the other end to a patient in cancer you wouldn't necessarily know. There is
just like in the hospital room where they pull the drapes around, and that's a great sound barrier. Yeah, carry on. Sorry, Sam.
There is an explosion of virtual care platforms by private companies now, and I'm not that comfortable with the security of them. So, for example, and I don't know if it's secure or not, but people are using Google for virtual visits. Some people are using Zoom for virtual visits. And I think we know that Zoom isn't safe. So I think in order to maintain a level of trust and acceptance of virtual care requires some certainty as to the privacy and confidentiality of the platform that's being used.
Yeah, that there be standards.
Okay. So Jeff, are you investigating now, or is your College of Family Practice investigating what other options you would have other than what you have very successfully developed currently?
Right now, I think as the others have said, it's evolving, and I think we all need to look for a better standard and offer it to our patients. And we do take most of our direction from our family practice groups within the province, and I think they will continue to help us source these other technologies.
Okay, thanks. Virtual care can be used for group therapy. Any experience? Anybody?
I've used virtual care to participate in massive group exercise groups for people with decreased mobility.
Okay.
Yeah, I think it could absolutely be used for group therapy. It could be used in any way in which people are wanting to, have the will to increase the access to that service and have participants that want to engage in it through that medium.
Jeff, if you had your wish going forward, what other providers in your office would you include in a virtual care visit?
I think the sky's the limit. I think having access to community pharmacists would be great. I think the biggest one though that I see are the in-home nursing personal care providers that I think would be most helpful in improving the patient care experience. If we could speak directly, have a virtual visit with the patient in their home with the PSW or the RN in the home. I think that would be fantastic going forward.
Okay. On the same subject as other providers, right now, if a patient is identified as a potential contact of infectious disease, COVID specifically, they're asked to isolate for 14 days. I heard some very positive comments coming from some infection control people or from some public health people that they actually set up virtual visits to follow these patients. Is that being done in this area, or is that just something that is unique? Any of you know a follow-up by public health or infection control for patients that need to isolate?
I don't know exactly, but I can't imagine it wouldn't be. I could imagine that will potentially be part of the work that I'm doing going into this long-term care home, as it makes sense. And why wouldn't you?
Okay. Jeff, do you know for this area at all?
I honestly don't know how much that tracking is happening virtually.
Okay, there's a couple of other situations where I've, Jeff, you still work in the ER, right? Yep. So this was a report out of Hamilton and a report out of CHIO where they've set up virtual ER visits. So you contact through some hospital link and schedule an appointment with an ER doc for an assessment of some rather acute or a problem. Any experience, or do you know, have you heard of that, or what would be your comment? Do you think it would work?
I don't know. I certainly haven't had any experience virtually through the emergency department. I can certainly, I think, see how it would be an effective, at least initial, I think, triage tool for the team, the triage nurse and the physician to get a better sense of what the patient appears to be like at home. I think it would be really challenging to provide care in that context virtually. I think some of the examples that I can think of that are a little bit similar, though, are systems that are evolving with respect to supporting emergency department physicians with critical care and having a patient with you in the department, but having expert consultation available virtually through the telemedicine network. So that I can see working quite well when we're needing extra support in the critical care cases. But I haven't had an experience, I think, triaging or assessing a patient virtually through the ER.
Sam, you've got a very unique group of patients and a unique group, well-defined, and a unique group of doctors who want to do this and work with you. Do you see you branching out into other areas?
We've looked at other things. One is we find that virtual care is very well received for mental health counseling. Mm-hmm. So for some reason, the distance seems to make patients more comfortable. We've looked at ER diversion. It's a scary notion for us, but the idea is that when a patient goes to emerge, they're ranked from 1 to 5, and 1 being the most serious. Sometimes a lot of the 4s and 5s, spend a lot of time waiting in emerge, and if there's a way of diverting them, especially during COVID, that's promising. So we've looked at that, but that's something that clinical experts would have to look at. We've also looked at hospitalist roles. So some small rural hospitals have difficulty attracting physicians to work as inpatient hospitalists. And so the idea, and it's being done in the Maritimes, is that the hospitalist is actually a head on a cart that gets rolled from bed to bed with the patient's chart, providing ongoing services. And that has had some success. But obviously, it's where there is an adequate supply of hospitalists.
Okay.
That would work.
Okay. So lots of opportunity coming down into the future. How have you heard? What's the government intending to do with the current system? I know that, first of all, the fee schedule, which was enabled very quickly to make this happen, and maybe one of the reasons why it didn't happen before, is actually pretty favorable. Do you think they're going to continue it, Jeff? And if they don't, what's going to happen?
I don't know, right? As far as we know, these are temporary fee codes from the Ministry of Health that keep getting extended over month after month. I think they will persist in some form to, I think, enable this ongoing virtual care. But I think time will tell. Yeah.
Okay. Because it's the current arrangement with the ministry and with the colleges is very conducive to making this happen.
Right.
And I think, personally, I'd be disappointed if that changed, but, there is a limit to how much, and having to prioritize where we put the biggest of our dollars and the biggest of our people too. Is it the right amount of time that you should be investing as somebody that's got many, many talents? It's extends far beyond the money. So this question comes from a gentleman who wrote me a very, very long email. I don't want to give out any words, but he said, "I'm no babe in the woods." So I think based on that, he's over 60, not under 60. How's that? For not being privacy. So he had 3 questions. What alternative do people have when their doctor won't see them? So if they say they call and they want to be seen and they don't have a virtual system or a virtual system that's readily active, what can they do? Sam, is your organization open? Jeff, do they just call around to other doctors? What do they do?
I'm smiling because this is a complicated question, a complicated answer. If somebody has their own family physician or nurse practitioner, we will not see them. Our mandate is to only see people who don't have access.
Okay.
What that person could do is either go to a walk-in clinic or a telemedicine clinic that will see any patients, or emerge. I will say that depending on what funding formula the doctor has, if that patient goes elsewhere, his family doctor will be dinged, penalized a small amount financially, because this patient did not have access to that physician, his own physician. Okay. So that's an incentive sort of to see your own patients.
Perverse incentive, yeah. Okay.
Yeah, so I think that those are the options, so walk in, telemedicine, or emerge.
Jeff, do you think that's going on? And if so, how would you suggest a patient might handle it?
Right. No, it's a really, I think, challenging and I think, frankly, disappointing experience that viewer described to you. I really feel that we do have an obligation to keep seeing our patients or at least offering alternatives. And I do think that it does happen sometimes. We do, when I work in the emergency department, hear sometimes some similar stories where people are really having difficulties accessing their primary care providers. So unfortunately, I think it is happening. I hope it's not happening very widely, but the emergency department is an option. There are some walk-in clinics that will see patients as well, but I really think patients. I think it's disappointing, frankly, and I'm just it's just not good.
Have the walk-in clinics gone to a virtual system of some kind?
Yes, there's been a enormous growth of these telemedicine clinics that, as I said earlier, only deal with what we call episodic care.
Okay.
The rashes, the bites and things. They're not going to look at a chronic condition and manage it for you. The best answer, which Dr. Galiski referred to, is that they go see the doctor that knows them best.
Okay.
And that's the best solution.
Okay. Okay. This gentleman had several questions, and maybe we've already touched on a few, but I'll ask one of the other ones. It seems logical that the average doctor would earn more under a virtual care system. It's more efficient, perhaps, just pick up the phone and dial, and would likely have fewer expenses, less staff. Do you agree with that statement? And if not, could you tell me why?
I think these are really detailed questions, and I think, as you've alluded to, Keith, I think the physician compensation models in Ontario are quite complex. I would suggest that I am no more efficient doing a virtual visit. I think there's a lot of efficiency in seeing someone in person, a lot of, again, that nonverbal communication, a lot of nonverbal cues that you can pick up on. So I think contest that it's more efficient virtually. And again, as Sam mentioned, with our current payment models, there really is a disincentive to not having access or not seeing your own patients. So I don't think that the incentives or the fee services for virtual services are any more lucrative than seeing someone in person.
Okay. Thanks for the clarification. You, Jeff, talked about using telemedicine several years ago as a resident. And this question could go to all of you. Do the staff that you interact with or the people that are taking virtual calls get any special training for how to make those conversations easier? Like, it's very different seeing somebody face to face and perhaps even touching them, because that's nice, or shaking their hand when they come in. But when you're seeing them virtually, you're looking at them differently. They're only seeing one side of you. They're not seeing all of you. Do you get any give any special educational advice to people that have adopted virtual programs? Lisa, why don't you handle that to start, because you're trying to train people to get more involved.
Absolutely, and yes, there are, and there's guidance documents available that explain, how to have a good quality video conferencing appointment from the patient side. And it does have to do, looking at your lighting around you, making sure that you can see yourself, that you can hear yourself, that you've tested your equipment, that you're not speaking at the same time, because there could be a slight delay.
So I got to do this right now. They tell me that I've been so interested in the answers that I haven't paid as much attention to the time. So let me conclude. It's time to wind up. I must say a big thank you to our three speakers, to Sam for your perspective and your humanitarian approach to this whole issue, to Jeff, who brings us frontline experience, and to Elisa, who they've told me I forgot to introduce at the very beginning. My apologies, first of all, but I certainly appreciate you being here and giving your perspective as a nurse, and wish you all the best in your new challenge with the Beaten Home. We'd also like to hear from you, our viewers. First of all, we thank you for being here tonight. But if you could send us a quick email, Jared's email is up on the screen. Tell us if you like this. Tell us if you didn't. Tell us if you watched us on TV. Tell us if you watched us on online. And just for those friends that you want to tell if they want to see us tomorrow, it will be on demand on Rogers TV. So thanks again to all of you. We've appreciated the attention, the questions, and the answers. And we'll see you on 6 weeks for December the 3rd for Living Your Best Life with Arthritis. Good night. Thank you.
Thank you.
Thanks so much.